Hi, everyone. Welcome back to Medically Speaking from UCLA Health. I'm your host, Dr. Eve Glazier. Today, we're talking about ketamine, MDMA, and psilocybin. These are treatments being studied seriously in academic medicine, and they deserve the same combination of curiosity, rigor, and caution that we would bring to any emerging area of care. Psychiatry has helped many people tremendously. Medications, therapy, and other treatments remain essential. But for some patients, symptom relief is incomplete, and they've tried multiple approaches and still feel stuck. And at the same time, there's growing attention to trauma, meaning, and patterns in the nervous system that may not fully shift with symptom-based treatment alone. And I think that's why part of these therapies have generated so much interest, not simply because they're novel, but because they may change the therapy process itself, in addition or instead of just brain chemistry. So today we're going to talk through why these therapies exist, what they're trying to treat, how ketamine, MDMA, and psilocybin differ, what the research shows so far, and what safe, responsible clinical care actually looks like. And throughout the conversation, we're going to keep one bigger question in mind. Are these new drugs or a new way of understanding healing, one that focuses less on suppressing symptoms and more on restoring flexibility, connection, and a life that feels livable? I'm joined today by my colleague, Dr. Jessica Jeffrey. She's a psychiatrist here at UCLA Health Semel Institute. She works in child and adolescent psychiatry, trauma-informed care, population behavioral health, and she's also trained in ketamine treatment, MDMA-assisted psychotherapy, and integrative psychiatry. She is such a rock star. I have been asking her to be on this podcast for months. I'm so excited she's here. Jessica, thank you.
Oh, Eve, it's so wonderful to be here. Thank you for having me.
I'm thrilled. Before we get into the therapies themselves, I'd love for listeners to know a little bit about you. I mentioned you're a child and adolescent psychiatrist, but tell us what drew you to psychiatry in the first place?
Absolutely. And can I just say also, wonderful framing for the episode today, and I feel like I don't even know if you need me. Like, I think I can go.
No.
Like, that was excellent.
I was like, that was really long now that I'm reading it out loud.
Really there you go. That's the synopsis there. Yeah, but what drew me to psychiatry? I've just always been interested in, what makes people tick. Like, what is it about this complex being that is us?
Yeah.
I would just say, going through med school, I was always interested in being with people, learning about their stories.
Yeah.
And I just think psychiatry there was no choice, really. I had to go into psychiatry.
I love that, especially thinking about people as stories.
Yeah, absolutely.
And then, I know you have a background in integrative psychiatry. Could you tell us a little bit about that?
Yeah, absolutely. So really, this is an approach, like a holistic approach, looking at the person. So, right now, actually, I'm furthering my education even in women's integrative health. So
oh, wow.
Maybe we can talk about that
I would
later,
love to, of course.
That is also another area. But yeah, absolutely. It's really just like looking at the whole person again, And I think integrative work is really about that healing approach.
Mm-hmm. I'm always interested, because we've had so many wonderful colleagues on here who are integrative dentists, as an example, have an integrative approach to endocrinology or nutrition. I'm wondering, and just keep this in mind for our conversation, like, when is integrative actually going to be normalized that actually will just be the curriculum?
Yeah.
But there are these separate curriculums now, right?
Absolutely. Well, let me just tell you, it's something I'm working on.
Yeah.
So, I do a lot of teaching at the university, as you know, particularly in our trauma clinic, our stress, trauma, and resilience clinic, and in bringing the lens of psychedelic therapies. Mm-hmm. I just gave a lecture yesterday, actually, on ketamine-assisted therapy, and also bringing neurofeedback to the clinic as another adjunctive way to look at trauma or to approach trauma. So, yeah, I think, really, we're really learning more. We're exploring in this area at the university, and really trying to integrate into our treatments. And
it's so exciting to hear how everything just is constantly evolving, and I'm sure obviously you're so dedicated to learn, continuous learning as well. What pulled you to the psychedelic-assisted psychotherapy conversation, because we won't go into it on this conversation, but Jessica is also, involved in building mental health care systems for UCLA Health and bringing behavioral health to all of our communities. What's been this pull towards, the trauma informed psychiatric care that you've been involved in?
Yeah, absolutely. And I think it's also related to the population health approach, just to kind of, touch on that overlap. But again, it's really about the word healing. And so, I think in psychiatry, as you mentioned a moment ago, we've really been focused up to this point on symptom management. And, healing can occur. And I would say, our psychotherapies are excellent, but they take time.
Yes.
And it's really finding the right approach for the right person in terms of the psychotherapy and really, investing the time in the psychotherapy. And, there are some disorders, some symptoms that are really hard to reach with psychotherapy. So, for instance, you mentioned trauma. So, for PTSD, we do have treatments that work. Prolonged exposure therapy, for instance, cognitive processing therapies in the adult world. But it can be very hard to stay with the therapies because part of the therapy is exposing yourself and actually working through the trauma, which by nature is something, understandably that somebody would want to avoid, right? So the psychedelic therapies really help people approach that from a standpoint where they can, process the traumatic memories. They can work with them in a way where the defenses are lower and there's more self-compassion. And we can talk a little bit more about that.
Yeah, maybe it would be helpful to take a step back too and just, for our listeners to just define even what psychotherapy means.
Yeah. Absolutely. So sort of in a standard context, psychotherapy there can be many different kinds of psychotherapy, but really psychotherapy generally involves working with one therapist. So it's a one-on-one, interaction where you may look at past events, current ways of thinking, current behaviors, and work through hopefully future goals. So really, how do you resolve the past and how do you work toward the future? Right. And there are different psychotherapies for different disorders or different symptom clusters. So what therapy for obsessive compulsive disorder would look like would be very different than a therapy for, say, post-traumatic stress disorder.
Got it.
So that's very specific.
No, that's super helpful. And like you were saying too, I think that sometimes people assume, right, if you're struggling with something like, oh, you got a therapist. And so like then all of a sudden you're going to be, quote, fixed. And even just hearing about the fact that it's time intensive. You have to find a person that you connect with, and then the therapies themselves can actually be challenging, and we'll get into those in a minute.
Yeah, absolutely.
I thought it might be helpful just to kind of put a face to the conversation a little bit, and so I just kind of created a composite patient for us, meaning just not a real patient, but just someone we can all latch onto. Let's call her Maya.
Great.
She's 38. She's a working mom, very high functioning on paper, but privately she's exhausted, and basically says, she's been depressed since she was a teenager. She's tried multiple antidepressants. She's done multiple kind of courses, maybe of psychotherapy. She's tried lifestyle approaches. She's tried meditating, sleeping. She exercises. So all the things, and she feels like she understands herself. The psychiatry words that we say, she has insight, right? And I think she can even explain where the pain comes from. But what she really describes is she feels like her brain has just one default setting. And so speaking of stories, she feels like she's like, I just have this one story of myself and I keep returning to it no matter, what I do. And she has heard about psychedelics and she wonders, listen, is this going to maybe be a therapy, of something that's going to unlock me or kind of unlock these patterns of thinking that I've had for a while. So again, she's just a composite, but if someone like Maya, and she's latched onto psychedelics because there's obviously a lot of conversation out there. When someone like Maya walks into your office, what are just kind of some of the things you listen for first?
Absolutely. So for somebody like that, what we're looking for is, what have they tried in the past? Where are they in their life? What goals do they have? Because that would really kind of lead me down different potential treatment options. So again, let's think holistically.
Yes.
So I want to bring psychedelics in, but I also just want to be mindful of the whole picture because even when I'm talking with people about psychedelics, I let them know this is a tool that we have in our toolbox to help you, but psychedelics are very promising. I'll just, also want to be clear that they're still, for the most part, aside from ketamine, we're still researching them.
Yep,
although
absolutely.
there is a lot of really, and I'm involved in the research as well. And
So
there's a lot of great data.
Yeah.
So I'm very optimistic. So I want to be really clear about that. But it still is at this point, very much in the research realm, at least for MDMA and psilocybin. So let's sort of think about her now and sort of, I just want to frame that ketamine might be an option, but the others at this point would be a research study option. Right?
Yeah.
And we can talk through.
I think that's so important though too, because and this is why I'm so grateful you're here, because I do think that there's just a lot, I think it's great, right, that we're even having these conversations, at least, when I'm I'm on social media, when I'm, reading, even mainstream news, like these things are out there. And so I think people are going to latch onto them. But I really appreciate that when she comes in, you're also saying, listen, let's also take a step back. And where there's that integrative or holistic lens is really kind of the approach.
Absolutely.
I also hear, even in my primary care practice, I will say the same thing about high blood pressure medication. I'll be like, this is a tool, right? This is a tool with exercise, with meditation, with stress reduction, with nutrition. So I think that's also seems like an important part of even your approach as a psychiatrist to say, sure, let's think about, these as tools.
Absolutely. And we're thinking exactly along the same lines. So so in terms of like what I would say for this particular patient, of course, we would look at all those things. So we would look at, what is your lifestyle like? Diet, exercise, and just around the diet, I want to say, nutrition.
Yes.
Right? Like fresh, foods, like lots of vegetables and fruits. Like really staying away from the standard American diet, or processed foods. The exercise piece, meditation, wonderful. Time in nature. I talk a lot about social connection.
Yes.
And we were talking a moment ago before we were on the air about my work with adolescents, and that's actually a lot of the work I do with adolescents as well. Is who are you seeing socially? What's your support network like? What are you doing for fun? Can we bring in new activities, for instance, new hobbies, things like that. And of course, all of that applies for adults here.
I love it.
And then there's a medication piece. There are other interventions. So we won't talk about this today, but, there are also other neuromodulation techniques like TMS.
Yeah, we had Dr. Strauss on.
Perfect. Yeah. Yes. So you've talked to the experts, so there's that. Again, there are also neurofeedback adjuncts for specific symptom clusters. And then we could talk ketamine.
Yeah.
And so,
it's just so, but it's so, I have to say, even just as I'm a layperson, when it comes to psychiatry, I hope our listeners hear this too. There's so many tools and there's so many evolving options too. And whether it's, it sounds like one or seven at the same time, but I think that's just a really encouraging, positive message.
Absolutely.
Because I think, when I think of this, Maya as our composite patient, I think a lot of people feel stuck. Yeah. Is that something that you hear?
Oh yeah, and that's actually one of the reasons why I would recommend ketamine for a patient. So we're actually moving along, I think, in the line to really
I want to hear about it exactly. Because sometimes, right? Do you have patients who kind of they're like, listen, I've been doing all these things, it's just nothing's moving the needle.
Yeah, absolutely. And in my psychotherapy practice, I may have some patients like that, and so we'll get to a point where I'll say, you know what, this might be a good time. Why don't we come in and do some ketamine sessions?
Yes.
And see if we can maybe move beyond that stuck point and see what opens up for you.
That's so interesting. Yeah, so even just talking about ketamine, my limited information about ketamine is that, it was first developed as an anesthetic. But Can you orient us a little bit about it as a medication now?
Absolutely. So with ketamine, there are many different ways to administer it, and I'll tell you a little bit in more detail about how we do it at UCLA. But just to know that there are IV clinics. So
intravenous, through a vein.
Absolutely. Intramuscular injections and therapy can be paired with that, although not at the time someone is receiving the ketamine for IV or intramuscular, because the doses are so high that generally during those types of procedures, the patient is more internal, or like Maya would be more internal, and then we would process afterward. Maybe the next day, or there would be a little processing after the session, and then we would meet later that week. But then there are also lower doses that can be sublingual or intranasal. And in my clinic, we actually do what's psycholytic therapy, which means ego loosening, as opposed to psychedelic, which is ego dissolving. So we do psycholytic therapy with intranasal ketamine, racemic ketamine, during our sessions. And I can tell you a little bit about what that looks like.
I can't even. It's so funny. I'm a physician myself. I can't even picture this. Can you walk me through actually what this looks like?
Yeah, absolutely.
Even just making the decision together. I'm curious when you. Exactly. You're talking to your patients and then you say listen, this is something for us to consider. What's the conversation like? Are most of your patients, I guess, into it or?
Yeah, I would say, similar to you, having heard about it through media, and it's just a pretty hot topic right now. I think, people are curious about it.
Right.
And then we have a discussion about whether it might be the right fit at the right time. Because there are some people, that it may not be the right fit. Right. So we really talk about, is this the right fit for you? And if so, when?
Right. And I also imagine too, there's probably people who just want to feel so much better.
Yeah. Yeah, absolutely. And that's, yeah.
I had no idea that it came in all of these different forms. I mean, of course, but I'm that's amazing. Tell me what seems to be happening, I guess, that you're seeing even in the sort of just on the chemistry level, with ketamine.
Yeah. So, so I'll just say across the board with psychedelics, I would say there's two main things that we see. And I think this is really important, for people to get a sense of, because it also impacts the therapy we do, and how we encourage people to take care of themselves after any kind of psychedelic treatment, and then what we call integration, which I can talk about.
I want to hear it all. Yes.
So, two of the things that happen. One is that there is a loosening of the default mode network. So there's a network in the brain that is a self-referential network. This is a network that is active when we're having daydreams, we're thinking about ourselves. Like even here, while we're in the room together, there may be, thoughts that you're having in the back of your mind about, what's my day going to be like? Like, how is this going? How was my morning? Like, it's just constant thoughts that we all have.
Just like in the background.
About ourselves.
Right.
In the background. Right. Just, again, like no judgment on them, but it's just the constant thoughts. Now, for people with depression or anxiety or OCD, we find that this network think of it as it's a very sticky network. It's hard to break it up.
Yes.
And when those self-referential thoughts become negative, like you can imagine this is a loop that people are experiencing all day.
Right. And people are ruminating.
And they're ruminating.
Yes.
Absolutely. And this is really difficult.
I see. So people can get like stuck in their own kind of thought patterns.
They're stuck.
Especially if they're negative.
Absolutely.
Right. Absolutely. And I can see that being really deleterious.
Yeah, absolutely. Yeah. And so now what happens with with psychedelics, so with ketamine, with MDMA, also with psilocybin, we see that there is a temporary loosening of the default mode network. And it allows opportunity just for the brain to rest and start to think about things in a new way.
Oh my gosh.
Right? So what happens during the treatment and in the hours and days following the treatment, it's an opportunity for us to really get in there and work with a patient and really help them to see, can I create a different story here? Is there a different narrative? Can I look at the world a different way and see myself in a different way within the world? So this is the prime opportunity for that. So, Mendel Kaelin, who is also a researcher, he does a lot of work on psychedelics and music, which is really another fascinating topic. But he describes this really well. So imagine that you're skiing and you're going down a slope and everybody kind of launches off in the same way. And there's grooves in the snow. So everyone's going down the slope and it's kind of the same grooves every time. Right. Now, what happens with psychedelics is imagine you can push off in another direction.
Right. And you can put footprints into a whole new snowfall.
Absolutely. So that's number one. Number two is an increase in brain-derived neurotropic factor, which
I'm going to ask you to definitely translate that.
That
sounds sexy.
It does. BDNF is what we call it. But really, so we think about this. Think about it as a chemical in our body that helps plasticity with our neurons. So helps essentially, you mentioned, in the opening, so eloquently the connections in our brain, right? The neuronal connections. So this helps us to increase synaptic connections and remodel our brain as well. So new connections, new growth. So, if you think of both of these things, as I think of probably the two biggest things with psychedelics combined happening they're happening at the same time. Right? We are taking the opportunity to really capitalize on that.
Right. So this sounds like there's this, I didn't realize too, I'm sorry to interrupt, that there was this kind of target time period. So I mean, basically you have a ketamine session, whether it's through any of these routes, the nose, muscle, the vein. Then you're saying that in addition to that actual session where there's these changes in the brain, there's timing of therapy, right? Of the psychotherapy. Does it only last in your body for a certain amount of time? Is that why the time that you're having these follow-up sessions matter?
Yeah. Well, in terms of the plasticity piece, I definitely say 3 days out is a great time to do a lot of work, but, could be even up to a week out.
Yeah.
Right. But the way psychedelic therapy generally works, just to give you kind of a little bit of an outline,
Please,
because I think it will speak to maybe what you're asking. We do preparation sessions. So this is where we really talk about what are your goals for therapy? What intentions do you have, right? And we might do a really comprehensive inventory of your life as well. So I would also look at, physical health, emotional health. I would look at your interactions with the environment, community, social, just a general holistic review. We talked about integrative approach, right? And then we have the treatment sessions. The sessions themselves, just, I guess in case people aren't aware, they involve music.
Okay.
They involve eye shades. There may be some time that the participant, or in a study we call the participant, in the treatment we call a patient, is spent going internal and really experiencing the medicine themselves. And then in a lower dose of ketamine, there will be times where they may come out and want to talk to us about what's happening. Right. Generally, for ketamine, there's one therapist in the room, but for psychedelic research and in larger doses of MDMA or in psilocybin, there's generally two therapists in the room.
Okay.
Why? So a couple things. Those sessions are very long. So a ketamine session might be an hour to 90 minutes. An MDMA session, it can be like 8 hours, 6 to 8 hours.
Yes.
And a psilocybin, same.
Okay.
So, back in the days in the 60s, they were doing LSD research, and those were 12 to 14-hour sessions. You really need to have...
You're right. There's overtime for the staff, right?
You need a couple folks in the room.
Right.
And also just, they can be really heavy sessions, and you want to make sure there's a lot of support in the room. Yeah. So there's that piece of it. Now, during the actual sessions, we always, remind people of their intention, but we say hold it lightly because it may come, but it may not. But really, like with psychedelic research or psychedelic therapies in general, the standard approach is to really think about the inner healer. So, and I love this. I actually love this. Because
I love that.
This is like, the frame, and I so believe this is true, that I am there during a psychedelic session. I'm there to be a guide and be support, and be of a support, and create a safe environment for that person. And I take the stance that I don't know what's most important for them. Like what they actually know inside. They have this sort of inner healer, if you will, an inner voice that will determine for them what needs to come up during that session. And it could be, and if you look at some of the MDMA research, this certainly was the case, that, and MDMA, I'll say is for PTSD. A lot of the research is in PTSD and a couple other things as well. But in that research, it was thought that vets with PTSD would be discussing their traumas overseas during the therapy session, and that's probably what would come up. But they took the inner healer approach. And actually, for many people, what came up were childhood traumas, a loss of a parent at a young age, challenges in the family. We wouldn't know that, right? And so I think that's just a prime example. Like, just whatever comes up is meant to come up, and we work with it.
Yeah.
So we say, trust, let go, be open, in the words of Bill Richards, and we're going to work with that approach.
But that's transformative. Are people surprised when you frame it as you're the healer? I mean, it gives the patient, all of us as people, this incredible agency, right?
Yeah,
and sort of sense of, especially if you're feeling, profoundly depressed or traumatized, that this is within you.
It's so beautiful because that is so true. And this is actually what we say about psychedelics or breath work, or there's actually a lot we could talk about in terms of healing, but we say the medicine is in you. And what psychedelics do is they allow the opportunity for the healing. So if you think about, this, again, if you want to think of the science, the default mode network, the BDNF, but it creates this opportunity, again, for, going deeper, having a little bit more, less defenses, more self-compassion.
Yeah.
Trust amazing. In the process, and then those messages come. But they're there. But I think what the psychedelics really do is allow us to really have a better understanding of and be more in tune with ourselves.
Amazing. So, I mean, even let's take a ketamine session. And so it sounds like the environment matters, the music, the framing. How many sessions does someone usually do, let's say, of ketamine?
So it really depends.
Okay.
It really depends.
So it's definitely individual.
So I would say I'll give you a standard.
Sure.
So maybe we'll take Maya, right, for example. It could be that we would start with a series of 12 weeks or so.
Okay.
We would meet twice a week though. So one would be to actually do the ketamine. So she would have that at home. We would prescribe a ketamine for her, not to take by herself at home, but to take in the session. And then there would be another meeting to do integration work.
Yes. Yeah. Tell me about the integration.
Yeah.
Yes.
So the integration piece is so important. And I actually think this is the hardest part of it. Because the integration really is meant to capitalize on the lessons learned during the medicine session or sessions. Because that whole pattern of preparation, medicine, integration may be repeated multiple times, right? So if I'm working with someone for 12 weeks, there may be 12 cycles of that, right? And we're building each time, which we can do with ketamine. Now, with others, with MDMA, it doesn't work that way. We need at least a month between sessions. With psilocybin, we usually have a month or two at least between sessions. And we can talk about that because every medicine is different.
Yes.
Right. And I also just want to make the point that we are still learning about which medicine for which person at which time.
Yes.
Right. And so we're getting a sense of which medicine for which conditions. But in terms of the integration, what we do is we really this is where, again, and to quote Bill Richards, because he's so amazing, that he's a very seasoned psychedelic researcher, and he says that integration is taking the mystical to the practical. Now, some people will have mystical experiences. It's not uncommon, and they're beautiful. They're beautiful to witness and to just feel that energy in the room. It's really about how do you take that experience and take those lessons and bring them to the everyday, because we live in the everyday.
Yeah,
we live
exactly.
So this is what we do. So we have to say, what did you learn that you may want to bring into your life that you could, change maybe how you are. I mean, in your everyday interaction. So, for instance, to go back to Maya, if Maya is having challenges maybe in her relationship or doesn't feel connected to her family, and there's a sense of loneliness or disconnection, it could be, for example, that maybe there were some insights or lessons that came up during her ketamine session.
Sure.
Right? And then one of the integration pieces we might do is work on, well, how do you create more intimacy in your relationships?
Right, in a practical way of connecting.
What would that look like for you?
Yes. Right. Well, what would it look like for her? Right.
Exactly.
I love that you're not imposing your recipe, that everyone's kind of writing their own.
Everyone is so different.
Right.
And I think that's part of the beauty of it, know, and one of the things I'll just say that I love, I mean, as you can tell, I love being a psychiatrist. This is I'm
about to become a psychiatrist listening to you. I'm like,
I feel like this is not work. This is just, I feel it's such a treat to do what I do every day. But, but the truth is that, I think also it's so intellectually stimulating for me because, I don't need to and I don't want to plan out what needs to be in a session. I can be flexible and be there for somebody. Yeah. Whatever comes up, and we can think in a way that's flexible and we can be creative together, which is so. Which is wonderful. I mean, it's
such the most beautiful part of being a human being. Yeah. What is has anything surprised you kind of along the way as you've been learning about these treatments and now administering these types of treatments?
Yeah, I mean, I think kind of what comes to mind is I initially thought that dose mattered in terms of higher dose, bigger experience, and I'll just say that in some of the psilocybin work that we're doing. People can have very profound experiences even on low doses. So again, it's so individual. And I think just really speaks to, we have to take everyone, take the person in front of you, right? There just isn't one, it's not a one size fits all.
Yeah. No, and I think that that's the wisdom of it. Yeah. I want to go back to just the sessions because I think you've been, really, it's nice to hear how kind of responsibly you're talking about everything too, and I want our listeners to get that message as well, because you mentioned all the different ways of getting ketamine and how we're prescribing it, and obviously the thoughtfulness of the programs and the clinical trials, which we'll get into more in a second. But I do want to make sure that people listening, what distinguishes a responsible, ketamine program from a place just offering an infusion?
Absolutely, yeah. So I would say for anybody who's looking for ketamine treatments, really research the place first. So find out who is going to be administering the treatments. Ask around.
Yes.
I mean, word of mouth, I think, is really important. Ask if you know anybody who's received treatment there. What was their experience during the treatment? I think that's really important. And find out about the therapeutic aspect. You don't have to receive therapy from the ketamine clinic itself if you have a therapist that's comfortable with it. But, I mean, really, like people who I know who are involved in ketamine treatments or who are going through their own treatments, I say, like, you owe it to yourself. You're putting all of this energy into getting treatments. And like you want to have the best outcome, like you owe it. And and again, the integration piece, the therapy piece afterward, it really is the hardest piece because that's where the real work happens.
Right.
But you owe it to yourself to do that.
Right. The hardest, but it sounds like has the most like durable effects, meaning like that will last kind of the longest.
Absolutely.
Okay, that's great. Is there anything else we'll keep going back to ketamine, but anything else before we move on to MDMA? Any kind of limitations that people should know about either? Just having these good conversations.
Let's see. I think I would just be mindful.
Yeah.
Again, I just want to stress the therapeutic aspect. Oops, sorry.
Please.
The therapeutic aspect of it because, there is ketamine is, people like it. So I just want to address that.
Yeah,
I want to address that. Like people like it. We've all heard stories in the news of people who, were abusing ketamine and it is, easily abusable. So, I just say make sure that whoever you're working with is prescribing responsibility. You have the therapy along with it because, it's very easy to use it recreationally or maybe even be prescribed initially, but then take a little bit more than normal. And, it as a field, we really haven't quite yet got a handle on like how long to prescribe for someone and how, like when somebody is used to taking ketamine, do we dial that back a little bit? Because, the hope over time is that, for most people, you would be able to eventually be on your own without the ketamine, right?
Right.
And so I would just say it's just being emphasized.
That's essential. I so appreciate you saying that. Well, I am curious. I mean, where's the sort of line between like, it makes me feel so good, I want to, possibly abuse it versus I'm getting relief from it from my deep pain?
Sure.
Is that a weird question?
No.
Yeah.
No. Not at all.
You know what I mean? Like, so where does it like, you know what I mean? Like go. I mean, granted, I like propofol for my colonoscopy now, but like, I know I shouldn't use it for like my insomnia. You know what I mean?
Yeah. Okay. Next time. Okay. Yeah, but I think that's also the discussion with your doctor, right?
Yes.
And I think and I would just say bring it to the forefront.
Right.
Like, I love to have honest conversations.
Right.
And just say,
to be like, it feels so good. And be like, okay, well, why does it feel so good? Right.
And so I think,
how can we get it?
I would ask, what's your relationship with it?
Mm-hmm.
What's your
Yes.
Eve, what's your relationship like with your ketamine?
Right.
Let's talk about it.
It's a great question,
Let's talk about it. Yeah.
Yeah.
And it's not, and again, I just also, want to emphasize it's not a one size fits all, right? It could be for some people, like they may need to be on it a little longer. Like, and, there is data on ketamine for pain. And maybe, for somebody that might be appropriate, right? But it's a conversation to be had.
And an evolving conversation. I'm always like, no matter what the medical, again, I don't say just medical condition, anything we're struggling with, I think always just requires this ongoing dialogue.
Yeah.
Okay, this is great.
Okay, absolutely. So let's go.
Okay, but these are important messages. I mean, and again, they're not either, I don't see these as either or messages of like, this is great, but it's more of just like, it's part of the whole, your word, holistic conversation.
Yeah, it's just part of being informed.
Right, definitely.
Yeah.
Okay, let's talk about MDMA. I mean, I think a lot of people, understand MDMA as ecstasy, but in a clinical setting, tell us about it and what's different.
Yeah. So MDMA, I'm very excited about MDMA. And full disclosure, I have a study coming up.
Good. Tell us all about it.
MDMA. So, so MDMA thus far has been researched for PTSD, couples therapy. There's a lot of great data for couples. Mm-hmm. And also, there was a study that came out, actually it was quite a while in the 90s, but Charlie Grobe here at UCLA did a study on, do you know Charlie?
I do, yeah.
He's great.
Yes.
He's great. So he did a study on looking at autism spectrum disorder and social anxiety and looking and using MDMA. So there is, more to be discovered, but certainly a background in those areas. So for MDMA, acts a little differently than ketamine. I didn't mention this, but ketamine is an NMDA receptor antagonist. It's
not MDMA, but
NMDA.
Right.
Yes. So just sorry to go back to
like a neurotransmitter.
Exactly.
Right.
So just to kind of increases glutamate in the brain, and it's just to set that aside.
Okay.
Now, or MDMA.
I mean, if you think it's hard for our listeners, it's hard for us too.
It's hard for
all
us.
these
It's hard for
acronyms.
us.
Yes. Okay.
But you trust me.
Yes.
You don't want to go through the whole name.
Yeah.
So for MDMA, it increases serotonin, norepinephrine, and dopamine in the brain, and also increases oxytocin. So oxytocin is a bonding hormone.
Yeah.
So one of the things that happens with MDMA is that it allows people to access memories that are really challenging, so traumatic memories, in a way that is without all of the emotional reactivity. So, and also increases connectivity, like interpersonal connection. So essentially what happens is during this therapy, you feel more connected to your therapist. You feel like that there's more trust. There's more compassion for self, more compassion for others. And when the memories come up, people are able to talk about them in a way that they aren't feeling so reactive, that they become either hyper aroused, which would be that sympathetic, like fight or flight response, right? Like the response that makes you want to run out of the room, or hypoaroused, which is dissociation, which can be like a complete disconnection,
like detached,
and dissociation.
Okay.
Now, if you're outside of your window of tolerance, which it would be outside of the window of tolerance means hyper aroused or hypoaroused, it can be very difficult to process the memories because really to process them and work with them, we need to be in a state where, we can do that in a way that where we're regulated.
Right.
So the MDMA, sorry. Now I'm gonna get confused. The MDMA really allows folks with PTSD to bring up and work with those traumatic memories in a way that's just more accessible.
Right. I can see that. I mean, and right, because I don't mean to be reductive, but it seems like if you've been repressing things that are very, very painful, so if this allows more emotional openness, and I'm guessing kind of trauma processing.
It's all trauma processing.
I see.
And I also just want to emphasize like that with the oxytocin piece, I really think that's huge in the therapeutic relationship, because a lot of people with trauma, and even who have like big traumas, like so say somebody who is in war, I find that there's also not always, but often an attachment trauma at a young age. So a lot of the people I work with had childhood traumas, and maybe and it could be an actual trauma, physical abuse, sexual abuse, neglect as a child, or it could be an attachment mismatch and feeling and chronic feelings of invalidation even. But when that is the baseline in terms of like somebody's experience, it can be very difficult to trust and very difficult to open up during therapy.
Sure.
Hence why, those therapies I mentioned before, like the PE, the prolonged exposure, the cognitive processing therapies, when we talked about different types of therapies, at the beginning of our conversation, it's very hard to do those therapies because you need to be able to trust the person in front of you and be open, number one, and then you need to be able to recall what happened. And generally what happens, if you're not able to regulate, you start to recall the memory, and you're either sent into hyperarousal or you shut down in hypoarousal, and then the progress of the therapy stops. And the truth is, many patients drop out.
Right.
So with the MDMA therapies, the data looks fantastic. You see that people are able to access the memories. They're able to process them. They're in what we think of as a safe container, a holding environment with two therapists. The music, the eye shades that can come in and out is needed. Again, it's that whole inner healing approach, right? We may, if the trauma doesn't come up, we may have an agreement in advance that we would say, hey, anything coming up about that incident or, whatever it is. And if they want to go there, great. And if they don't, that's okay too. We just follow their lead.
But you do a little asking in advance.
It's always an agreement in advance.
I think that's so amazing. So there's a lot of consent and trust even.
It's all about
for the
trust.
Therapeutic.
Absolutely.
That's great.
So we will make sure that that's an agreement in advance. And again, we honor what comes up for somebody. And I think, again, because it's really about their inner healer.
So do patients then, if they have a session, do they remember what they felt? Are they able to recall 2 days later, I remember the session, I remember remembering this trauma. I remember what we talked about. Do people remember the details?
Yeah, for the most part, people remember. And what we do encourage people to do after a session is write notes. So, I encourage people to journal, or if it feels right to them, to draw, but really to kind of capture in some way.
Right.
In some traditions, psychedelic and breathwork traditions, which are also traditions that can lead to expanded states, we encourage people to do mandalas.
Tell me about that.
Yeah, and that's really beautiful too. So the mandala essentially is, a circle, a blank circle on a page, if you will, and then we just encourage, just to draw whatever came up for you. And I can tell you, no two mandalas are alike, and it just symbolically can really tell the story. Yeah, there's so much symbolism in these experiences, which is another reason why I love the work. But, again, it's about different ways of processing and trying to retain, some of the narrative of what happens or some of the feeling of what happens.
Right.
Because with trauma, too, one of the reasons why I really am appreciative of this approach with psychedelics is it's the healing doesn't just come through talking about it, but there's a felt sense of it.
Got it.
And so somebody needs to feel.
Right, viscerally, like deep inside.
Yeah, what comes up for them around the trauma. How does their body feel when they talk about it? And then how does it feel in resolution?
Right. But then, so I'm guessing, so in these sessions then, people can encounter the trauma without reliving it, right? And like you were saying, without having this physical response, right? Or another physical detachment or this fight or flight, but without processing it and feeling it, but without it being kind of clouded by the trauma, the fear,
exactly,
anxiety.
And I'll just say there might be some reliving, depending on the person.
Yes.
Or there can be just a different kind of recounting. So it really depends on the person. But I think really again, it's able to access some memories with these different sensory modalities. And then, we capture those again in different ways and work with them afterward in the integration. So some of the integration, to kind of bring it full circle, might be cognitive in nature. Some of it might be somatic work.
Okay. Can you define cognitive and somatic for everyone? Yeah.
Cognitive could be thinking about, analyzing or working with the way somebody is thinking about a situation.
Okay.
Right? So, how does that situation what does that situation lead you to feel or think about yourself?
Okay.
Right? So there may be more of that approach. There might be a somatic approach that we would take, and that would again be working with the different bodily feelings that come up, like tightness in the chest, tension in the muscles, headaches. There might be some people that every time they think about a specific traumatic incident, they get a headache or they have pressure on their chest.
Right.
So we would work through that and what is that telling you? Can we be with that and can we work through that together? So it kind of allows us to move into these different paths. Another one just to mention is spiritual. Because, again, people can have mystical experiences with psychedelics. And, I think it's so beautiful, although it doesn't, and I just wanted to be clear, it doesn't always happen. And if it doesn't happen to somebody, there is absolutely nothing wrong with the fact it didn't happen. But there can be really mystical spiritual experiences where there's a feeling of oneness between everyone and everything, right, and really a sense of interconnection with all beings. Whatever that looks like for them.
Yes.
Right? And really working with that in everyday life, which in psychiatry, for the most part, I was not trained in that when I was in psychiatry residency. And I think that it's a very important part of someone's being, right? Its meaning, its purpose, as you mentioned, in our opening. So, anyway, those are just 3 examples of things that we could focus on in integration. But there are, many, 20 plus things
I'm so fascinated and so interested. With the trauma and the PTSD, the post-traumatic stress disorder. Do we still use the word disorder?
Yeah.
Okay.
Yeah.
So am I incorrect then in understanding that healing, though, and again, I love the inner healing, is best achieved when things are processed? I mean, is that kind of what these therapies are predicated on?
Yeah.
That there has to be some processing of it?
Yeah. I think, the inner healer, and this is a Groffian approach. I just, if people are interested in learning more about it, kind of came about in the 60s with the work then. But that approach really it guides us to the place that we need to look. right? And then we really work in the integration with what would be best to focus on following that medicine session where we had the lessons learned from the healing approach. Does that make sense?
It does, but I guess I'm asking, like, in order to even just find your own healing, it has to be looked at.
Yeah.
Right, that you have to be doing the looking in some way or another.
Absolutely. And I think we're just honoring that.
Yes.
Because I think, probably, like, we all have that, right?
Yeah.
It's just a matter of, like, are you listening to it? Mm-hmm. And I think with psychedelics, again, it kind of, it maybe clears the space a little bit in your mind and allows us to really be attuned to that. I mean, how often, like, just even taking the psychedelic part out of it, although like, I think it is a key part, but how often does someone just even, like, go to a sound bath and like lie there and just be internal, or just any kind of time spent for say 2 hours plus just listening to yourself. It's very hard to make the time, number one, and number two, even when we do it, that default mode network and that self-referencing network is usually kind of on loop. And so it may be that you start analyzing everything about yourself, but that this inner healer is, like, somewhere in the mix, like pushed down at the bottom, but you just can't hear it.
Why? I mean, I'm just going to ask a big self as construct question. So sorry, we're going to go to the consciousness place for a second.
Because no, I love it. Yeah.
Why do you think human beings have evolved to this place where things, where our default network is like this?
Yeah.
Do you know what I'm saying? Like, why do we even have these sort of constructs of ourselves where we push down our emotions so much, or these experiences that we increasingly, it seems to me, and that's why I'm glad that this conversation is happening, that we need these tools, right? So whether they're sound baths, meditations, nature prescriptions, right? To be unlocked, why is it so hard to look for ourselves? Like, what's happened over time, do you think?
Absolutely.
Sorry, I know it's an existential question a little bit, but
it's a beautiful question.
It's, I'm always like, why do all of us need so much more serotonin? Like, what's happened as we've evolved as humans, where our biology hasn't changed, but the world has?
Yeah, and I think that's the answer, right? I really do feel like the world has changed over time, right? I mean, there's so many pressures on us on a daily basis. Between family, work, what's happening in our community, what's happening in the world. I mean, I think even with information, it's interesting that psychedelics are there's a resurgence at the same time as, all these apps and AI.
Yes.
And you think that we're just, we're exposed to so much more than we used to be.
Yeah.
I also think it's kind of, loss of community. If I and I realize that this is very person dependent, but, we are a very individualistic culture.
Yes.
And it's a very different story than, working in a more collectivistic culture.
Yeah. I mean, you have to wonder, again, and I'm very, like, a huge proponent of all of these therapies. I mean, a whole other conversation is even just for betterment and optimization, but right here we're talking in kind of in the therapeutic space especially. But, the things that we're aspiring for, which is, examining our interiority, or, feeling closer to ourselves, leaning into connection with others, right? So it's sort of, how can we do these things with these therapies and with other tools as well?
Absolutely. And again, like, to bring it back, to the integration piece, because the integration piece would be also where we would bring in other tools.
Right.
But community is a piece of that. Right. And it often is. I mean, I would say that a lot of the people that I see are pretty lonely and they feel very isolated. I mean, they just feel very isolated.
Right.
And so a lot of the work that we do is just how do we integrate back into a community and create meaningful connection.
Right. And I imagine people feel, loneliness, like you can feel far away from yourself, I mean, I think I've seen so many of my own patients, friends and family, if they're depressed or anxious, it becomes this own thick cloud where they even feel detached from their own inner self.
Absolutely, from their inner self.
Right.
And physically, you may be living with, your partner.
Yes.
And living with your family, but feel very lonely.
Right. You feel really disconnected.
Yeah.
So just a note, we've talked a little bit about psilocybin, and it's true. I think people, and there's such fascinating history and, its other label of magic mushrooms. But What's happening in the brain with psilocybin? So we talked about ketamine and MDMA, but what about psilocybin?
Yeah, so very similar to what we talked about before, which I think is a nice theme in terms of the psychedelics themselves. It acts differently. So this is a serotonin 2A receptor agonist. So it activates the receptor, so it works in a different mechanism. But again, like think about the default mode network, think about the brain-derived neurotropic factor. But the effects of psilocybin are very different than MDMA. So MDMA, like just to go back to that one, because I want to compare, is very can be very activating. And
Activating is such a medical word. I use that one all the time.
Oh yeah, so we should probably say that. So can really increase energy.
Yes.
Some people really want to talk on
increase intention.
Yeah,
right.
increase feelings of love and connection. We talked about all of that. So in contrast, so psilocybin is not, although some people can feel anxious on it, it's not necessarily activating or it doesn't give people the same kind of energy. But the psilocybin itself can kind of create more of a kind of a detachment, if you will. People can feel like they're kind of in an alternate world. It's very internal. Some people will talk when they're taking psilocybin, but most people, I think, spend a lot of time internal. There can be visual changes. It can be very profound experiences. I think that with the psilocybin, I would say there's maybe a greater likelihood for mystical experience on psilocybin, although it can happen on anything. But yeah, it's just a different. I wish it's some kind of hard to describe. It's just a different.
So, just a note about my question about like the mystical experience too. So, but what we're also saying though is that these experiences already exist within us. It sounds like we're almost kind of unlocking or giving access to these things that are already inside of us.
Yeah, people can have mystical experiences spontaneously.
Right.
Some people are more able to do that than others, but breath work, meditation, there are a lot of ways to expand your consciousness. Not just psychedelics.
Right. Exactly. Exactly. Right. Yeah. It's not an either or for sure.
Yeah.
So interesting. And I mean, I've heard a lot about with the psilocybin too, that because you talked about the default mode network, right? Yeah. And kind of sometimes what can lead to rumination, right? So thinking the same thought over and over again, really fixating on, certain patterns, right, of thought and behavior. Right. So reduced kind of rigidity of thinking. And I guess that goes to your colleague's skiing analogy, right?
I love that one.
Yeah, it's so, because it's so visual too.
It's so true. I mean, it's just,
I'm like, oh my God, like what ruts are we rerutting every day, right? And I mean thank you too. And I want to be mindful of your time. I think you mentioned kind of the settings for all of these, because I think a lot of the public story, kind of focuses on these molecules or these different substances. And I just want to emphasize what you're saying is that so much kind of matters about the overall container, the whole story, right? So you mentioned like the preparation, I think what you're saying is that we're monitoring everyone, right? And then this integration and the follow-up is also so much part of this whole story of these therapies.
Absolutely.
Okay, great. Yeah. I mean, in the integration, I have to tell you, I think that the integration part of the story is not out there in the mainstream. I just,
Yeah, we need to do more on that.
No, it's so fascinating. What are you talking about? You have to come back every week.
I know.
We have so much to talk about.
Yeah.
Really quick, I have a couple asking for our friends, if that's okay.
Yes.
Quick questions that people like myself Google at 2 a.m. Can people be on these, go into clinical trials or be on these therapies while they're also on other psychiatric medications like antidepressants?
So that really depends.
Okay.
Yeah. It just really depends on the medicine. I'll address it for ketamine.
Sure.
For ketamine, yes, you can.
Okay. Great. And so ketamine, I'm just going to ask this, is ketamine addictive?
Well, people really do like ketamine, so yes.
It can be.
It can be. Yeah.
And this was a question that came up a lot when I was doing some research. Will I lose control while I'm on these medications? Well, or I'm in these sessions?
So, yeah. So let me answer. So, yes. I mean, in the sense of these medications can be very hard for people who really like to be in control, because part of the frame of the session is trust, let go, and be open.
Right.
And so by the very nature of the work that we're doing, we're saying, let go. Like you're in a safe and supportive environment, and it's okay to let
Right.
go and see what comes up.
Yeah, I know. You're like the answer is yes.
The answer is yes. But there's actually one.
Yes, please.
I want to say because it's I think relates to the control, because I think for some people, the control is, I don't want to have like what's considered a bad experience.
Sure.
And I would say there's no bad experience. There can be difficult experiences, but even difficult experiences can be really therapeutic, and we work with it.
Right. I just want to know, I mean, as a psychiatrist, I mean, listening to you talk about this is truly like one of the most beautiful experiences I've had as a medical professional, just because I'm like, oh my gosh, look at all of these things that you're thinking about and caring about, and not just about like with these different therapies, but about like your fellow human beings. And so I want to just know, as a psychiatrist, how has this made you feel about your profession?
Oh yeah, I'm excited about where we're going.
Yeah.
And I'm very excited for what the next 10 or 20 years is going to bring. But I think it is a bit of a paradigm shift, right?
Yeah.
So
Yes.
it's really focusing on healing.
Right.
And I think this is a beautiful opportunity for that, to really see, how we can take each individual forward, which will then I think, translate to community, if I may be so like bold as to
Absolutely,
say.
of course.
And there will also be a place for medication management in our current therapies.
Right.
I think it's not an either or, but I think it's a lovely, it's just a lovely opening, a lovely opportunity to really help someone reach their full potential. So like right now we're talking about symptom management, and at some point we can talk about like enhancement of well-being. But
Absolutely.
there is kind of, when I'm working with my patients, we're addressing symptoms, but it's never that. Like really, like our we may have target symptoms, but we're actually really looking at like, what brings you meaning in your life?
Right.
What are your goals in your life? Like, what would you like your life, like looking back on your life?
Yeah.
What would you like to have felt like your life meant? Right. And so that's actually what the conversation really is.
Right. And along the way. And yes, and I'll bring you back, because I mean, that's what I think is so interesting, is this deeper question that it feels like psychiatry is asking, which is like not just suppressing suffering, right, or alleviating a symptom of suffering, but how do we best live our lives, and how we tell the story of ourselves to ourselves.
Yeah, absolutely. Yeah.
Okay,
Well
I'll let
said.
you go.
Well
This
said.
is so hard for me. Okay, sorry, they're cutting me off, but because you have actually like real patients
gotta
to
go.
tend
I
to and
wish I
make
could
their lives
stay.
better.
I know.
You're so amazing. I
you.
can't thank you enough. I just think that it's so wonderful to hear about the work that you're doing, both, the sessions, the clinical trials, which for everyone listening, those are where we, advance medicine and how we're innovative, and these emerging tools that really not just ask these questions, but is just this new approach, I think, to how we heal, and we're our own inner healers. I can't thank you enough for coming. To our listeners, thanks for listening.
Thank you
Stay
for
curious, stay
inviting
healthy,
me.
take good care. Jessica, you're just amazing.